Hello, everyone. My name is Falah Adnan, and we are at the end of our day, so we're going to get right into it. Here's a quick look at the patient's past medical history with specific regards to speech pathology, in that he was independent for communication and cognition and managing complex tasks such as medication, finances, and driving prior to admission. The speech pathology evaluation in rehab is multifaceted due to the wide scope of our practice, and this is typically reflected in our order set. For our gentleman here, his oral mech exam indicated right-sided orofacial deficits impacting his sensation, his labial and lingual range of motion, strength, and coordination. Further assessments indicated that he had a reduced speaking rate, articulatory imprecision, and irregular prosody. He would typically demonstrate breakdowns at the multisyllabic word level and was approximately 90% intelligible in conversation to an unfamiliar listener, which is pretty high functioning for a post-stroke patient coming to rehab, but we'll see how this impacted his daily routines in a little bit. His clinical swallow exam indicated oral dysphagia, primarily with difficulty with chewing, manipulating, and forming a bolus. He also frequently reported biting his right lip and cheek, which was his affected side, and contributed to his hesitancy for trialing regular solids, which was his baseline diet. We will typically complete an instrumental swallow study for this patient population given the high prevalence of silent aspiration in the post-stroke population. And for our gentleman here, his modified barium swallow study indicated no airway invasion. So he had a functional pharyngeal swallow. We did see some retention in the proximal esophagus, for which a GI referral was completed. SLPs will typically refer for ENT consults if there is a presence of dysphonia or vocal changes or a concern for vocal fold involvement, possibly as seen on a fiber optic swallow exam. However, luckily for this patient, his receptive, expressive language, and vocal quality and cognition were all within functional limits. So his primary speech deficit was in the form of motor speech production or dysarthria. Taking a look at this from the International Classification of Functioning and Disability, the ICF model, these deficits contributed to this patient's ability to be able to communicate in group or suboptimal settings. So think noisy environment like a restaurant or a grocery store, and also to consume his regular diet, which he did prior to the stroke. Furthermore, this would have limited his participation in public readings for a program that he had been a part of for the past 20 years, which was an integral part of his role and his identity. Some outcome measures utilized for the speech pathology world are the American Speech Language and Hearing Association's NOMS, or National Outcome Measurement System. So as you can see, this patient scored a level 5 on admission for his motor speech, which indicates participation restrictions based on communication ability. The functional oral intake scale developed by Crary and colleagues was used to objectively rate his swallow function, and he scored a level 5 on admission due to concerns with reduced oral intake and also functional ability, and required him to be on a dysphagia diet at the beginning of his stay in rehab for safety reasons. This is an example of what the functional oral intake scale looks like. And as you can see, level 7 is the highest with no restrictions. Speech pathology utilizes similar principles of neuroplasticity as mentioned prior. So what this translates into is our sessions consist of salient stimuli. In this case, it was passages that the patient was familiar with already during his public readings in front of an audience, and high frequency of repeated opportunities to practice the targeted skill or task. In this case, it was utilizing whole body motor speech and speech intelligibility strategies. For specificity and transference, we will typically target syntactically complex sentence structures because there is evidence to support that it has shown to generalize to less complex units, such as word or phrase level. So we will typically avoid doing drills at a less complex unit because of the lack of generalization. Intervention is typically a dual-pronged approach, restorative and compensatory, which aligns with the patient's long and short-term goals, respectively. On the upper left here, you're going to see the Iowa Oral Performance Instrument, which is an air-filled bulb that is placed between the dorsum of the tongue and the hard palate and is designed to progressively increase the resistance against which the patient has to exert effort. We typically use this for tongue strengthening based on the principles of progressive muscle resistance strength training. On the bottom right is a respiratory muscle strength trainer, which is used to improve cough strength, which has been shown to indirectly facilitate airway protection during the pharyngeal swallow. On the upper right is an example of a communication board, typically used for patients with aphasia, most commonly seen with our left hemisphere CVAs. This board can then be individualized to suit the patient's specific needs and visual acuity level. And finally, for patients that have cognitive challenges, we focus on tasks that the patient needs to be able to manage once they get home. And an example of that is medication management, especially now that they are going to be discharging home with probably a lot more medication than they were used to. So, and we will typically introduce pill boxes, simulations to target memory and executive functioning goals at the same time. Compensatory treatment targets immediate functional needs in the form of whole body strategies or environmental modifications, in order to facilitate effective communication, cognition, and swallow function, not necessarily in that order. One tool that was clinically effective for our gentleman was the use of biofeedback. So specifically the use of a mirror to help promote oral clearance because he did have right-sided pocketing during his meals, and also speech-to-text apps and voice recorders for immediate biofeedback and self-monitoring in order for him to be able to complete self-correction, which is the goal. As you've heard already, there is a huge team that is involved in patient care that makes the patient outcomes what they're able to be. I'm going to mention and highlight just a few of them that we work with most frequently. So co-treatment with music therapy allows the patient to engage in diaphragmatic breathing, which helps promote improved speech production, and also incorporates the use of melodic intonation therapy, which we'll typically use for patients with severe aphasia or severe apraxia. Recreational therapy activities allow the patient opportunities to demonstrate carryover of learned strategies outside of a structured session. So, being able to engage in a variety of different backgrounds and contexts with familiar and unfamiliar listeners. As seen in the previous videos, when there are dogs present, the environment is pretty busy and distracting, and that allows the patient more complex opportunities to challenge themselves to produce, whether it's more verbal output or more intelligible articulation, whatever the targeted skill might be. We also aid in identifying patients that may need further services, such as a neuropsych or psychiatry consult, or those who need further visual assessment, especially because visual acuity plays such a significant role in stimuli selection during our treatment sessions. Communication with the PM&R physician occurs directly or in the form of weekly team conferences. From an SLP perspective, this is an opportunity for us to discuss any barriers to discharge, especially from a cognitive standpoint, or if there's a need for 24-hour supervision when they go home. which then further impacts case management and social work's discharge planning. Here are some videos of the patient's speech with and without strategies. He's talking about wood carving, which was a hobby of his.
It's best to start out with a small kit of quality tools because they will come already razor sharp. It kind of looks snaky. And Linda, being the terrific salesman she sold it for $50.
And back here is his pride and joy, the staff he carved himself prior to the stroke. Get at it? All right. Family training is typically ongoing throughout the rehab stay. We focus on carryover of learned strategies and any environmental modifications to the home and community setting. There are some patients that may need supervision or monitoring when they go home for adherence to aspiration precautions in order to minimize hospital readmission due to aspiration-related complications, or safety precautions just in general if they have memory impairments and need verbal cues to use their assistive device whenever they're mobilizing in the home. We complete education and family training for their primary caregiver or caregivers. And we also like to highlight their progress in therapy. So as mentioned prior, it was a lack of understanding of progress in therapy for this patient that was making his spouse concerned and overwhelmed with the prospect of a discharge date. And when we highlight that and the patient's family is able to observe how much progress they have made in therapy sessions, they're much more comfortable with the plan. And at the end of the day, that's a win. That's meaningful for the patient and that's meaningful for us as therapists. Continued therapy was recommended, and it usually always is. For this patient, outpatient therapy was recommended because of his higher level of functioning and easy access to transportation and a good family support system. However, home health, skilled nursing, and post-acute brain injury programs are also available options. For our non-resource post-stroke patients, we will typically send them home with a home exercise program and community resources for pro bono or sliding scale therapy services. And finally, discharge outcomes. So as you can see, this patient had a clinically relevant change for his motor speech. He was successful in being able to communicate with a variety of communication partners in a variety of settings, and was modified independent for use of strategies, which was the goal. Although he remained on a level 5 for the functional oral intake scale, he did advance from a minced and moist diet to a soft and bite-sized diet, according to the International Dysphagia Diet Standardization System, or the IDSI scale, which we utilize here at Houston Methodist to objectively standardize our diet alterations and modifications. And this advancement, diet advancement, allowed him to enjoy a greater selection of his favorite foods and thus improve quality of life. Thank you so much.